We have another excellent issue this month, beginning with an article from the New England Journal titled Semaglutide in Patients with Obesity-Related Heart Failure and Type 2 Diabetes, where we will be joined by Dr. Mikkel Kosebrod, first author of the article. Then an article from Diabetes Care on habitual short sleep duration, diet, and its relationship to the development of type 2 diabetes in adults. Then two articles from Diabetes Care. The first, tirzepatide versus basal insulin in people with type 2 diabetes and different baseline glycemic patterns. Then, early onset type 2 diabetes and tirzepatide, followed by a discussion of an article titled Cardiovascular and Mortality Benefits of Sodium Glucose Transporter 2 Inhibitors and GLP-1 receptor agonists as third step glucose-lowering medicines in patients with type 2 diabetes, a retrospective cohort analysis, and then finally an article on SGLT2 inhibitors and their continued use from the ambulatory to inpatient setting, where we will be joined by one of the authors to discuss this article. For our first article this month, we're going to discuss an article from the New England Journal titled Semaglutide in Patients with Obesity-Related Heart Failure and Type 2 Diabetes. Joining us to discuss this article, we are privileged to have Dr. Mikkel Kosebrod. Dr. Kosebrod is the Vice President of Research at St. Luke's Health System, Director of Cardiometabolic Research in St. Luke's Cardiometabolic Center of Excellence, and a Professor of Medicine at the University of Missouri, Kansas City School of Medicine. Mikkel, welcome.
Thanks so much, Neil. Always a pleasure.
It is. Now, this is an important study. Can you go over with us why you chose to specifically look at this question in people with diabetes? You had previously published on semaglutide and HFpEF for people without diabetes.
Yes, absolutely. So as you already pointed out, Neil, the STEP HFpEF program had two trials in it. The whole premise of the program was to try to understand whether obesity in people that have heart failure with preserved ejection fraction is not simply a comorbidity, but a root cause and a key driver of development and progression of their heart failure. And we, from the very beginning, decided that we're going to address that hypothesis, whether targeting obesity with semaglutide can significantly improve symptoms and physical limitations related to heart failure in this patient population in two separate trials in two separate patient populations. First, in people with obesity-related heart failure with preserved ejection fraction or HFpEF that didn't have diabetes, and the second in people with obesity-related HFpEF that did have type 2 diabetes. Now, the question is why analyze these two patient populations in two separate trials? Why not just do one trial where you have both types of patients? There was a very sound logic behind it. Our hypothesis from a get-go was that if there was a benefit of semaglutide in this patient population, it's at least partially going to be related to weight loss. And while weight loss might not explain everything that we see, it probably is an important factor. And we already knew, not just from trials of semaglutide, but from trials of other anti-obesity medications, that people with diabetes lose less weight than people who don't have diabetes, regardless of whether they have heart failure or not. So because weight loss was a very important component of these trials, we decided that if we already know that people with diabetes are going to lose quite a bit less weight with semaglutide versus placebo, we should evaluate them separately. And there were a couple of others. One is people with diabetes represent more severe phenotype of those with heart failure, including those with heart failure and preserved ejection fraction. And sometimes people with more severe phenotype don't respond to treatments as well, regardless of what the treatment may be. And then finally, people with type 2 diabetes also tend to receive certain medications that may potentially interfere with the effects of semaglutide, at least theoretically. So one example is medications like insulin, sulfonylurea, and the main interference in that regard is from a weight loss standpoint, right? Because if you're on insulin, sulfonylurea, you may be less likely to lose as much weight. And then on the flip side, people with diabetes are also more likely to be treated with SGLT2 inhibitors. And SGLT2 inhibitors actually have beneficial effects on heart failure. So there may be potential confounders in the diabetes, in people with diabetes that may potentially influence the trial results. So we said, you know what? We're going to make it a clean break. We will do one trial in people who don't have diabetes, one trial in people who have diabetes, and that way we have a very clear answer in both patient populations.
That's fantastic. Those answers are critically important. Tell us a little bit about the methodology for the study.
Yeah, and methodology, aside from concentrating on people with obesity-related heart failure, HFpEF, and type 2 diabetes, as in the presence of diabetes, both trials were conducted in a very similar fashion. And as you said, we already talked about the first trial, which showed very large benefits on heart failure symptoms and physical limitations with semaglutide versus placebo in the population of patients with obesity-related HFpEF, but who did not have type 2 diabetes. That we presented at ESC in 2023 and published in the English Journal of Medicine a few months ago. In this trial, so again, we concentrate on people with obesity-related HFpEF and type 2 diabetes, but otherwise, the trial was conducted in a very similar fashion. So patients that had obesity-related HFpEF and type 2 diabetes were randomly assigned to either semaglutide with a target dose of 2.4 milligrams once a week, or a matching placebo and treated for 52 weeks. There were two primary endpoints, just like in the first trial. One was change in heart failure-related symptoms and physical limitations as measured by the Kansas City Cardiomyopathy Questionnaire, which is a gold standard of assessing those outcomes in people with heart failure. And the second was change in body weight. And then there were a number of secondary endpoints, including evaluation of exercise function measured by 6-minute walking distance, looking at what we call hierarchical composite endpoints that combines clinical events of heart failure with changes in symptoms, physical limitations, and exercise function, changes in C-reactive protein, which is a measure of inflammation, changes as exploratory endpoints now in biomarkers of congestion. And while this was not an outcome trial, we also collected clinical events of heart failure hospitalizations and urgent visits, and we adjudicated those events as well.
Mm-hmm. Now, let's go into the results. And before we talk about the results, just give us a sense of the level of severity in this population. I noticed somewhere around half the people did have a hospitalization in the last year for heart failure. What level of heart failure, sense of severity, and then the results.
Absolutely. So this was an older patient population, as is very typical for people with HFpEF. They tend, on average, to be about 10 years older than those with heart failure and reduced ejection fraction. So we're talking about average age of about 70. These were patients that were symptomatic. About 2/3 had NYHA functional class 2, that's New York Heart Association functional class 2, and about 1/3 NYHA functional class 3 or 4. The Kansas City Cardiomyopathy Questionnaire, or KCCQ, at baseline was about 59 points, which indicates pretty significant symptomatic and functional impairment. And the 6-minute walking distance was below 300 meters, which indicates pretty substantial impairment in physical function. So these were clearly symptomatic patients with substantial burden of heart failure-related symptoms and physical limitations. From a diabetes standpoint, they were reasonably well controlled. Hemoglobin A1C was about 6.8% at baseline. And most of them had pretty long-standing type 2 diabetes. And other things to mention, probably just to say that the median BMI was roughly about 37. So and about 2/3 of people had a BMI of 35 and above, so clearly significant degree of obesity. And they were quite well treated from a heart failure standpoint at baseline. So they were receiving all the usual things that we typically see in patients with HFpEF. Roughly about 1/3 of the patients were already on SGLT2 inhibitors at baseline.
Fantastic. And what did the results show?
Yeah, so let's talk about the two or dual primary endpoints, the KCQ and body weight. So first off, there was a large improvement in KCCQ, which again measures heart failure symptoms and physical limitations in people treated with semaglutide as compared to those treated with placebo. The between group difference at 52 weeks was about 7.3 points, which is very, very similar to what we saw in the first trial in people without diabetes, where it was 7.8 points. And both of these represent very large improvements. When you put it in perspective of other treatments in HFpEF for this particular outcome, it's really the largest benefit that we've seen in this patient population when we look at heart failure-related symptoms and physical limitations. And by the way, the benefit was already obvious at 20 weeks, but it continued to be amplified. And the largest benefit was seen at 52 weeks at 1 year, which was pre-specified primary endpoint. When it came to body weight, there was also a significant reduction in body weight, not surprisingly, with semaglutide as compared with placebo. But the between group difference was about 6.4%. So 6.4% more body weight loss in people treated with semaglutide versus placebo. This is about 40% less weight loss than what we saw in the first trial, people without diabetes. So I'll pause here and just say one of the critical findings in this trial is that you have 40% less weight loss, but essentially the same heart failure, improvement in heart failure-related symptoms and physical limitations, which at least indirectly suggests that the heart failure benefits of semaglutide are probably not entirely due to weight loss. Because if this was entirely weight loss related, you would have hypothesized with 40% less weight loss, you would see a proportional reduction in heart failure benefits, but that's not, in fact, what we observed. And it's not just for KCCQ. We saw a similar improvement in 6-minute walking distance as what we saw in the first trial, similar improvements in hierarchical composite endpoint, similar reductions in C-reactive protein, similar reductions in N-terminal proBNP, which is a biomarker of congestion, all very, very similar to what we see in the first trial, even though you have about 40% less weight loss. So I think that's one of the key contributions of this trial to the field is to say, less weight loss, pretty similar heart failure benefits. And so it's likely, what we're observing in terms of, physiology or mechanisms of benefit here, yes, weight loss is likely a factor, but it appears that it's probably not the only factor that's important.
Yeah. It's fascinating.
Go
ahead.
Just very briefly, a couple of other facets just to add before we kind of go to the next topic. One is that we also, just like in the first trial, we saw numerically fewer clinical events of heart failure hospitalizations and urgent visits in people treated with semaglutide versus placebo. The number of those events was small, but again, it's a very similar picture to what we see in the first trial. Small number of events, but very favorably distributed to semaglutide versus placebo. And finally, on the safety side, again, just like in the first trial, we see fewer serious adverse events in people treated with semaglutide versus placebo, predominantly accounted for by fewer cardiac disorders in semaglutide-treated patients versus placebo-treated patients. But specifically when it comes to type 2 diabetes, we did not see any imbalance in hypoglycemic events, including clinically relevant hypoglycemia, which was the adverse event of special interest, so that the number of events of clinically relevant hypoglycemia was quite similar between the two groups. And we also did not see a difference between treatment groups in retinopathy and maculopathy events, which was another safety measure that we followed very closely. So I think that's kind of the bottom line summary of the results is that similar heart failure benefits despite less weight loss as what we saw in the patient populations that did not have diabetes, and very similar safety profile and also no imbalance, very similar safety profile to the first trial with fewer SAEs and no excess in clinically relevant hypoglycemia or retinopathy or maculopathy events.
So it really has added importantly to our understanding of HFpEF, and we're the GLP-1s will fit in. For our audience, I know when you and I have talked previously, you shared some thoughts about why you had functional outcomes and why you feel, I think correctly, that functional outcomes are really important. And I'll ask you to say a few words about that because some of our audience may say, huh, the SGLT2s were studied with an endpoint of heart failure hospitalization. Is this as important? And can you share why you feel this is an important endpoint?
Yes, it is critically important, and the key reason is I frequently talk about triple goal of care in people with heart failure, actually, regardless of what type of heart failure it is, whether it's with reduced EF or preserved EF. But the triple goal of care essentially is first to make our patients live longer, right, to reduce mortality or improve survival. Second is to try to keep them out of the hospital and emergency department, so reduce hospitalizations, emergency department visits. And third, and equally importantly, is to improve the quality of life, make patients feel better and be able to do more. Now, in people with HFpEF in particular, that third goal of care is absolutely critical. And the reason for that is because if you actually ask patients that have HFpEF what's most important to them, many of them actually say that improvement in their symptoms and physical limitations is as important, if not more important, than survival. Why is that? It's because that's what they have to live with every day. Heart failure is a very debilitating illness, and it's first and foremost clinically diagnosed based on symptoms. Right? It's a clinical syndrome that's based on symptoms, and those symptoms and physical limitations is what determines whether the patients can take a shower, get dressed, go for a walk in the park, play with their grandchildren, go shopping in the supermarket. It affects their daily lives. And it's that impact on their daily lives that they consider to be as important and sometimes more important than the outcomes we typically talk about all the time, which is survival and hospitalizations.
I think that's so important for us to realize, and you are such a wonderful advocate for the patient's voice. Um, Mikhail, how do you see this fitting in now to our treatment of patients with HFpEF? Are we now coming into a new paradigm of care?
I think we are. I think when you take a look at the totality of data that we have now, which is two separately conducted international randomized multi-center double-blind placebo-controlled trials of semaglutide versus placebo in people with obesity-related HFpEF, one without diabetes, one with diabetes. The totality of the data clearly shows that when you treat or target obesity, and when I say obesity, I don't just mean, obesity is not just about weight, and targeting obesity is not just about weight loss. And clearly, the data actually indicates it's not just all about weight loss, as I talked about a few minutes ago. But with that acknowledged, we have shown now in two separate trials that targeting obesity produces very large improvements, the largest improvements we've seen to date in this patient population in heart failure-related symptoms and physical limitations, and has a number of other downstream effects, including reduction in biomarkers of inflammation and congestion, improvement in exercise function, and actually a consistent signal across two trials, albeit with few events, towards fewer hospitalizations and emergency department visits. That's hypothesis generating, not hypothesis proving, but certainly the effects on symptoms and function are hypothesis proving in both trials with very, very compelling benefits. So what that means are a number of things. One is, I think it confirms the original hypothesis that we had, which is that obesity is not just simply a comorbidity. It's a root cause and a key driver of HFpEF development and progression, and probably the obesity epidemic explains why there has been such a dramatic rise in a number of people with HFpEF over the past 20 years. So what that clearly indicates, at least to me, is that treatment of HFpEF going forward in the future in people with this phenotype, with obesity-related HFpEF, is going to be extremely difficult, if not impossible, without addressing what's causing the heart failure in many of these patients, which is obesity. And I think it's very exciting, kind of as a clinical scientific hypothesis, which has been proven at least with these outcomes. Still needs to be definitively proven for things like cardiovascular death and heart failure hospitalizations. But at least for these outcomes, it's now been proven twice in two separate trials. And it's very exciting because it opens up a whole new avenue of targeting obesity as a modality to treat HFpEF, which has been very vexing clinical problem. It's the most common type of heart failure for which we have very few efficacious treatments. So now we have a whole new avenue. And of course, as you know, there is a lot going on in terms of clinical development of new anti-obesity medications. And I think this is a condition in which we really need to study them because that's where they're likely to be very, very effective. And so that's more on the clinical science part. On the clinical practice side, it, of course, gives our patients and us as clinicians taking care of our patients a new, completely novel treatment option to offer our patients where we can pretty clearly say, look, if we do this, we can be pretty certain that you have a much higher likelihood of feeling better and be able to do more. And maybe last thing I will say in terms of implications, we'll see what guideline developers ultimately are going to do with this data and where this goes. But one of the common questions that has been asked, actually two questions. One is, well, SGLT2 inhibitors are now standard of care in this population. Is it still effective on top of SGLT2 inhibitors? And what we showed in the New England Journal papers that we're talking about is that in the third of the patients that were on SGLT2 inhibitors at baseline did about just as well as everybody else. So it didn't matter in terms of heart failure symptoms and physical limitations, whether the patients were or were not on SGLT2 inhibitors. And we know that these two classes of agents have complementary and likely non-overlapping mechanisms of benefit. So that's number one. And the second question that's been asked is it just all mechanical unloading from weight loss? Essentially, is it just that people who have obesity lose weight and feel better? Or is semaglutide doing something fundamentally disease modifying, in terms of pathobiology of heart failure? And I think this trial now offers kind of your first glimpse to say it's not all about weight loss, right? And we actually have a second publication that came in the day after this one in the Lancet, where we show that people with more severe heart failure across the entire program, now combining the two trials together, STEP-HFpEF and STEP-HFpEF diabetes, people with more severe heart failure measured by various means had even greater benefit with semaglutide than those with less severe heart failure, even though they lost about the same amount of weight. So there are now multiple lines of evidence indicating that it's likely something fundamental to the pathobiology of heart failure that's changing in a positive direction with semaglutide, only part of which can probably be explained by weight loss and part of which probably has other mechanisms.
Wow. What critically important information that really is truly practice changing and stands to help a lot of patients. Dr. Mikhail Kosibrad, thank you so much for joining us, and thank you so much for going into that detail like you have.
Thanks so much, Neil. It's always a pleasure to be with you.
For our next article, we're going to discuss an article titled Habitual Short Sleep Duration, Diet, and Development of Type 2 Diabetes, published in JAMA Network Open. The objective of the authors was to investigate the association of the type of diet and duration of sleep with the development of type 2 diabetes. The data was derived from the UK Biobank. Baseline investigations were from 2006 to 2010. They were analyzed for the whole cohort between May 1st and September 30th in 2023, and they looked at the association between sleep duration and healthy dietary patterns with the risk of down-road development of type 2 diabetes. The median follow-up was 12 and a half years. There were over 240,000 participants that were categorized into 4 sleep duration groups. Normal sleep was 7 to 8 hours a day. Mildly shortened was 6 hours per day. Moderately short was 5 hours per day, and extremely short was 3 to 4 hours per day. Dietary habits were evaluated through a standardized tool, and a healthy diet score was given for each person, ranging from 0, unhealthiest, to 5, the healthiest. They used Cox proportional hazard regression analysis to calculate hazard ratios for the development of type 2 diabetes. What they found, and the mean age here was 56 years of age, during follow-up, 3.2% of the participants were diagnosed with diabetes. Adjusted for confounding variables, regression analysis indicated a significant increase in the risk of type 2 diabetes among participants with 5 hours or less of daily sleep. Individuals sleeping 5 hours per day exhibited a 1.16 adjusted hazard ratio. That's a 16% increase in diabetes if you sleep less than 5 hours a day. For people sleeping 3 to 4 hours a day, there was a 41% increase in the risk of type 2 diabetes, all compared to people with normal sleep duration. Individuals with the healthiest dietary patterns, not surprising, had a reduced risk of type 2 diabetes with a hazard ratio of 0.75 or a 25% decreased risk of diabetes with healthy eating. John?
So, Neil, I find this fascinating on so many levels, partly because I'm not a great sleeper. So I really think about this in three separate silos. The first silo is we live in a nation right now of people trying to squeeze the most work out of the day. So when you think back, Da Vinci slept 15 minutes out of every 4 hours. Tesla never slept more than 2 hours in a day, right? So people are trying to do this and they're sending emails in the middle of the night. And these folks, are kind of choosing their own course. And I think they know better that they should be sleeping better. I do talk about sleep at a physical. I talk about the importance of that. So that's category one. Category two is you and I see so many people who just say they don't sleep well. And, oftentimes you and I might be reticent to give someone a sleeping pill because studies have shown that it really only adds about 30 minutes to sleep to the average senior. We talk about kind of daytime sleepiness, and maybe that's really not great. And I think a lot of people in primary care aren't super happy about putting a 40-year-old on a sleeping pill for the rest of their life. But there are people who don't sleep well, and oftentimes there's a medical condition kind of attached to that. Maybe we need to be a little bit more kind of sensitive and maybe a little bit more therapeutic with that. The third category that I find most interesting in this topic are shift workers. So if we think about in the United States, about 6% of the US population work the night shift. There was a study out of UCLA to say that the average person who works the night shift sleeps 2 to 4 hours less than the average person working another shift. You and I have worked overnight as kind of residents, and we know that when you work nights, no one respects you sleeping during the day. And so that's a huge segment of the US population that are working for companies, and that's how we make our nation work. That there are people going to have to work overnight, not just in hospitals. And perhaps, though, if you are taking kind of a macro health version of this for companies or for healthcare in the United States, perhaps we need to put more structures in place to help workers who work third shift, who already, I've seen studies out there that talk about perhaps 10 to 15 years off their lifespan, just kind of being a third shift worker, and perhaps being more likely to find themselves in a category with diabetes might explain some of that. So for our next two articles, we're going to talk about two studies from diabetes care. First one looked at early onset type 2 diabetes and tirzepatide treatment, a post hoc analysis from the SURPASS clinical trial program. So in the SURPASS phase 3 clinical trial program for type 2 diabetes, tirzepatide treatment improved glycemic levels and substantially reduced body weight and improvements in cardiometabolic markers. This was a post hoc analysis that evaluated baseline characteristics of participants with early onset type 2 diabetes. That would be someone who developed diabetes before the age of 40 from the SURPASS, and assessed the effect of tirzepatide on glycemic control, body weight, cardiometabolic factors. So breaking down who was in the study, pretty even male to female. If you looked at early onset diabetes between SURPASS 1, 2, and 3, roughly it's in that 18 to 22% range of people who found themselves being younger. The people who were younger with early onset diabetes, though, younger by definition, were more likely in the study to have a longer duration of diabetes, had higher A1Cs, had worse metabolic figures, being higher body weight and BMI, had higher triglycerides, lower HDL, had a higher GFR and lower systolic blood pressure. But overall, kind of finding that the people who were in this early onset category did a little bit worse, and then looked at kind of what happens if we give people tirzepatide, and actually found that it didn't really distinguish its improvement. It helped people who had early onset diabetes just as much as it helped people with late onset diabetes improve that. So despite younger age, participants with the early diabetes had higher glycemic levels and the worst metabolic things, but the post hoc analysis had similar improvements in A1C, body weight, cardiometabolic markers with the tirzepatide, regardless of the age of diagnosis. Our second study, also in diabetes care, looked at the effect of tirzepatide versus basal insulin in people with type 2 diabetes and different baseline glycemic patterns. Again, a post hoc analysis of the SURPASS 3 and 4 trials. So they looked at fasting blood sugars. They looked at postprandial blood sugar control in patients with type 2 diabetes. And people were investigated in tirzepatide versus ideglodec or iglargine. And they looked at people who had low fasting blood sugars, who had low postprandial, low fasting, high postprandial, et cetera, down the 4 categories. And interestingly, what they found is tirzepatide versus degludec had a better improvement in A1C, an equivalent response with fasting sugars, and a better response for postprandial sugars. Comparing it to glargine, it had a larger decrease in A1C, again had an equal response to fasting sugars, but had an improved impact on postprandial sugars. So Neil, you're going to talk about the 2 articles.
Yeah, John, we really live in a new age of the treatment of diabetes. And you and I have talked about this a number of times, and these 2 trials further accentuate that. That we used to think of insulin as the go-to, the strongest medicine we had for diabetes, for lowering blood sugars. Clearly not the case. And I particularly like the first article here that talked about people who have younger onset diabetes, that's under 40 years of age, because we see a lot of them. In the trials, it was about 20% of people, and I've seen a good number of them come in on insulin. And this trial really shows that a better choice for those young individuals is tirzepatide. It did better than insulin at lowering A1C, had better metabolic outcomes, and maybe even, and we'll have to see this over time, might have better beta cell preservation, which is a big issue in people with younger onset diabetes. As far as the second article, you and I have talked about how tirzepatide has better glucose lowering, more powerful glucose lowering, A1C lowering than basal insulin. And here we see the details reflected in CGM and both fasting sugars and postprandial sugars. Our next article from BMJ Open Diabetes Research and Care is titled Cardiovascular and Mortality Benefits of SGLT2 inhibitors and GLP-1 receptor agonists as third-step glucose-lowering medicines in patients with type 2 diabetes. This is a real-world study, a retrospective cohort analysis. Now, we know that randomized trials have found that SGLT2s and GLP-1s have cardiovascular benefits for people with type 2 diabetes and atherosclerotic disease, those with chronic kidney disease, and those with heart failure. This study was a real-world study where they looked at the effect of add-on as third-step medicines of these two classes of medicines and the effect on cardiovascular outcomes in people with diabetes and the comorbid conditions described. And they compared third-step SGLT2 or GLP-1 to third-step DPP-4 insulin or TZDs. They looked at retrospectively a group of adults at 5 Kaiser Permanente sites who had diabetes and ASCVD, CKD, or heart failure, who had initiated third-step treatment between 2016 and 2020. There were over 27,000 patients in this group, adjusted risk ratios for GLP-1 and SGLT2 versus DPP-4 insulin and TZDs in the patient subgroups ranged from 0.22 and 0.55 for all-cause mortality. For MACE, that's major adverse cardiac events, from 0.38 to 0.81, and for heart failure hospitalization, 0.6 to 1.05. So really showing in this large cohort the benefits that we saw in randomized trials. John?
So, Neil, I find this to be kind of very interesting. Real world data. So, kind of what has happened in unionized practice. And interestingly, comes from a large American health system who they really should have kind of system-wise the ability to control some of the decision support that they're going to send out to their clinicians and to really be able to monitor what's happening. So I think, they have a dog in the fight. These aren't just purely kind of academicians who are kind of looking at p-values, et cetera. One of the things I think kind of taken away from it is just kind of how quaint third line therapy is, right? So when we look at the last few standards of care, right? If someone has one of these high risk things, they should be started on these categories of medicines, irregardless. So they have kind of moved from being in the way back seat in the station wagon to kind of sitting shotgun. So kind of very interesting kind of how that has changed. Someone's going to probably have to figure out kind of the macroeconomics of this. And, yes, you can have this 20% impact and, but what will it cost from a health system to say, we are going to put someone on some medicines to prevent someone ending up in the hospital from a heart attack, someone ending up in and out of the hospital from heart failure, or someone ending up on dialysis. Certainly the third category has the highest kind of price point, but the question is, does that price point translate to, a private insurance, or does that move on to Medicare, which is, someone being on dialysis as a designated kind of benefit in Medicare. So I find this to be very interesting, and it really kind of shows that this is something we need to be kind of thinking about, and I think most of us are still looking to kind of metformin as our first line agent, works well, available, cheap. We kind of know all kind of the ins and outs, but for many patients, a lot of these medicines are now, it's kind of a 1A and 1B.
Next, we're going to discuss an article from Diabetes Care titled Association of Continued Use of SGLT2 Inhibitors from the Ambulatory to the Inpatient Setting with Hospital Outcomes in Patients with Diabetes. This was a nationwide cohort study. Joining us to discuss this, we're privileged to have one of the authors, Dr. Elias Spinakis. Dr. Spinakis is Chief of Endocrinology of the VA Maryland Healthcare System and an Associate Professor of Medicine at the University of Maryland School of Medicine. Welcome, Elias.
Thank you so much for the kind invitation. More than happy to talk about this article. Thank you.
It is a really important article. Can you tell us why you decided to undertake the study?
Yes, that's a great question. So it came from a clinician perspective. We currently the recommendation is to utilize insulin as therapy as a way to treat hospitalized patients with diabetes, regardless of the outpatient regimen, regardless if they take any non-insulin medications. And this is because of concerns, mainly concerns that we have of safety for using non-insulin medications, but also because insulin is the most effective and the strongest, perhaps, medication to utilize in the treatment for patients with diabetes. Although insulin is the recommended regimen, there is definitely this concerns of hypoglycemia and also uncertainty of how to use insulin in the hospital setting. Now, on the other hand, we have in the outpatient setting a lot of different non-insulin medications, SGLT2, GLP-1s, different medications, novel medications, which they shown benefit. And they have a benefit that it's regardless of the effect that they have on glycemic control. For example, SGLT2 inhibitors, they are medications that have been found to be protective and have a benefit in mortality, in chronic kidney disease patients, in heart failure hospitalizations. So the question immediately arises whether someone should use SGLT2 inhibitors in the hospital setting, not only for convenience, but also because they may have a benefit in this environment. And there have been studies, randomized clinical trials, that they actually start SGLT2 inhibitors in the hospital. And they have shown some improvement benefits, post-discharge reduction in mortality, decrease of heart failure hospitalizations with or without diabetes. But at the same time, they haven't evaluated, studies have not performed to evaluate whether someone who is already on SGLT2 in the outpatient setting, at home, in the ambulatory setting, whether should be continue to use them in the hospital. And this was the question that we wanted to answer. If someone is receiving an SGLT2 inhibitor outside the hospital, should we continue to manage them in the hospital setting? And that's the reason that we wanted to do the study to evaluate it, whether it has some benefits in mortality, CKD, or length of stay, among other outcomes.
Critically important question. Can you tell us how you went about looking at this? Briefly, the methodology.
Yes, so this is an observational study. So this is not a randomized clinical trials that you have two groups and you start one to continue, the other one to discontinue. So it was a retrospective observational chart review. Not exactly chart review because we're talking about a large number of data, so a significant number of patients. And we focused at the VA data. We analyzed VA data in order to have, because it's an environment that we have access, but also it's an environment that you can have national-wide data and provide a comprehensive information for different covariates and different comorbidities. And at the same time, you have a closed environment. It's a relatively closed environment so that patients receive care only on that, and we can follow outcomes in a better way. So we use VA national data over a period of almost 8 years, and and there was all of them, they had diabetes, and all of them, they had SGLT2 in the outpatient setting. And some of them, and all of them, they were hospitalized, and some of them were continued to use SGLT2 in the hospital. The physicians decided to continue SGLT2s during that hospitalization, or they were decided to discontinue the medication. So that was the comparator, which was the group that did not receive SGLT2 inhibitors. And we also include a lot of covariates. For example, demographic data such as age, sex, race, the reason for admission, but also some other things like BMI, GFR on admission, blood pressure, whether they did procedures, surgeries in the hospital, but also several comorbidities that are important to account for. And in order to, one of the threat, one of the concerns that when you analyze data and when you do the statistical analysis is that, especially with observational studies, is you need to be account for confounding. For example, one question is if someone continue the SGLT2 inhibitors or stop the SGLT2 inhibitor, maybe not because it was randomly assigned, this is not a randomized clinical trial, but because a physician was concerned about the condition of a patient and actually discontinue the SGLT2 inhibitor, or actually may decide to continue the medication because there was a condition that made the physician to think, oh, you know, this patient may be managed better on SGLT2 inhibitor. Let me continue the SGLT2 for this type of patients. So in order to account for this, for confounding by indication, as we say, but also to be able to do a better analysis, is we did a propensity type of matching analysis. So we try to match the two groups as much as possible and try to account for all these covariates that we collected, demographics, age, for example, or procedures, or even, or more importantly, comorbidities. So these are the, and we did several models in order to try to understand and see the validity of our results in order to be strong and confident that what we report actually is as much as possible based on the observational data is the strongest available.
Elias, I'm so glad that you mentioned that, because that's the question that always comes to mind with observational trials, particularly in something like this, is there a systematic difference between the two groups and why decisions are made? And you answered that very nicely. Just so our audience understands, because you opened by saying we did a chart review and then you corrected, so, well, you know, it's electronic records. Share with us the number of people, because when we talk about both validity and your ability to sort through data, these were a lot. You looked at a lot of admissions. Is that right?
Yeah, so it was a significant number of patients that we included on this analysis, and it was not like some 100 charts or 200 charts or things like that. So the group that was actually continued on SGLT2 was 5,900 patients almost, and the SGLT2 that was discontinued was 30,560 admissions. So in order to do that, in order to analyze the chart, you cannot do it chart review manually, but you have a data manager which is familiar with the VA data and actually is running. You can pull the data by SQL or SAS, and you can actually get this data. And one of the things that the VA is really innovative in a way is that it's a national-wide system, as we know. Several hospitals are connected, outpatient clinics are connected, and they have created this Vinci workspace, which is a server which actually houses all the data. So it houses all the electronic health record data, and they collect there everything that you can imagine, all the information that's available on electronic health records, which is important. And it gives the ability for researchers to use them and analyze for any different reasons.
Pretty phenomenally powerful. Now, what we're all waiting for, what were the results?
Yeah, so what we find is that among the patients that they continue the SGLT2 inhibitors, there was a 45% decrease in hospital mortality compared to the group that the SGLT inhibitors was discontinued. In addition to that, there was a small decrease in the length of hospital stay and no difference in acute kidney injury, not a difference in acute renal failure. And these results were continued and became statistically significant even after accounting for potential confounders, major comorbidity differences, or even initial admission to the ICU unit or not. And to translate that in a more clinical, perhaps in absolute terms, if the adjusted death rate was 10 deaths per 1,000 admissions with an SGLT2 inhibitors, where the group that did not receive SGLT2 inhibitors, they had 18 deaths per 1,000 admissions among the group that was discontinued.
So you must have undertaken the study because you suspected you would see a result, but were you surprised to see this degree of effect?
So I was so the question. So honestly, when we start this study, the question we had a question: should we continue or not in the hospital? So we are open to any results that's going to happen, because and we know very, very strongly that in any scenario, either you continue or you discontinue, this is something that you need to report it, because there is no data. So we know that this is something that it was important to report for us. Now, it was surprising the rate of decreasing deaths. I can definitely say that I didn't expect something like that. I mean, we know from the outpatient studies, and we know from the clinical trials that have been done with SGLT2 inhibitors, that when they started the SGLT2 inhibitors in the outpatient setting, there was an immediately benefit. The first weeks of the first month of utilizing the SGLT2, there was a benefit in mortality on the outcomes. And that was surprising when I saw that actually from this major randomized clinical trial that was published several years ago. And that was a surprise that we had initially with SGLT2 inhibitors that were utilized in the ambulatory setting. So that made me to be honestly a little bit less surprised when I was thinking about that probably similar to what's happening to the ambulatory setting, this may happen at the hospital setting as well.
Yeah. So what are the clinical implications of this study? How do you feel we should use the results?
Yes, so I think this is right now the best data that we have. We don't have randomized clinical trials to support one way or the other, but based on this study that we have, I think we can definitely say that we should continue to use the SGLT2 inhibitors in the hospital setting, and even in the hospital environment, and especially, I think, to be honest, the ADA, the American Diabetes Association, now in the 2024 update, this is a new update of their guidelines. They now recommend SGLT2 inhibitors to be initiated or continued. So even continued, as we did, and this is actually after our study was published, during hospitalization for patients with heart failure. So this is actually a population that the SGLT2 inhibitors in the hospital setting, I think, should be continued or initiated in the hospital setting. I see also that I think what we have seen from this study is that SGLT2 inhibitors in the hospital environment may have significant benefits, and this may be not, and these are not related to probably to the glycemic control. This is irrespective of the glycemic control.
Right.
This is something that's happening by the medication because they have probably cardiorenal protective effects.
Thank you so much for going over this. I think this really is an important article that informs us with data that we did not have before. Dr. Elias Banakis, thank you so much for joining us.
Thank you so much for the invitation. Thank you.
For more information and links to the articles that we discussed in this issue, just go to diabetesjournal.org. Until next month, keep listening
and keep learning.